Good afternoon, everyone. COE Bowring and Lady Curzon Hospital, Bangalore welcomes all the participants for today's RDLS session. Today's topic is HIV and OI respiratory system, and the speaker is Dr. Arvind ML. Dr. Arvind sir is the professor and head of Department of General Medicine and the program director of the Center of Excellence in HIV Care at Bowring and Lady Curzon Hospital, Bangalore. He brings in 2 decades of extensive experience in healthcare and has authored numerous papers in both national and international journals. We welcome you, sir, for today's session and request you to start the session.
Warm welcome to all the delegates and respected doctors and the medical officers. So today, as Shweta has mentioned, the topic that we are going to discuss is about HIV and its opportunistic infections, primarily concerned with the respiratory system. So should we start? All the delegates are on the line.
Yes, yes, sir.
Okay, so this is a broader objective that we are looking to cover today. The introduction and its scope, Mycobacterium tuberculosis, Pneumocystis jirovecii pneumonia, bacterial pneumonia, Mycobacterium avium complex, Talaromycosis, and other pathogens concerned with pulmonary manifestations. So it's about preventable and treatable respiratory infections are seen in up to two-thirds of all people living with HIV. Frequent respiratory complaints in PLHIV are cough, dyspnea, and pleuritic chest pain, either alone or in combination. HIV-associated respiratory diseases, upper respiratory tract infections, sinusitis, and bronchitis. The pneumonias are the most diagnosed bacterial respiratory infections. So this is the slide that shows the correlation between CD4 count and the pulmonary manifestations. Primarily, mycobacterium tuberculosis, you can expect the CD4 count less than 400, bacterial pneumonia less than 250, suppurative lung disease less than 100, PCP pneumonias less than 200, MAC, that is Mycobacterium avium complex, less than 100 again, and cytomegalovirus less than 100. So tuberculosis can occur with CD4 count well with above 200, less than 400. So it's quite commonly seen in people living with HIV. So coming in detail about Mycobacterium tuberculosis, the most common cause of death in people with HIV, TB in HIV, that is any immunocompromised status, reduced ability to kill the bacteria. HIV in TB promotes host HIV replication. So this is very important. So HIV per se in tuberculosis patient actually promotes HIV replication and progression of to AIDS. So approximately 80% and 20%. So TB with and extrapulmonary TB in general population. And in people living with HIV, the extrapulmonary tuberculosis is way about 20% and stands at approximately 40%. So in Indian scenario, uh, now adults with latent tuberculosis infection develop active tuberculosis disease this is in the range of 5 to 10, 15%. Now those infected develop active tuberculosis disease in 5 to 10%. Increased risk of TB in case of HIV co-infection with or without ART is 21 times more than the regular population. And TB with HIV patients, as far as the statistics concerned in 2019, it stands at 71,000. So 71,000 people are affected with the tuberculosis among the HIV patients in 2019. So risk of developing TB becomes higher in people living with HIV. 3 to 10% persons develop TB and TB infected people PLHIV. HIV infected TB patients suffer much higher mortality than HIV negative TB patients. Recurrence of TB and long term post tubercular mortality among VLHIV are extremely high. And TB on HIV patients, inflammatory response to TB bacilli increases HIV replication, rapid progression of HIV infection. Among the AIDS cases, TB is the most common opportunistic infection. The mortality due to TB in AIDS cases is also very high. So coming to the clinical representation, features of tuberculosis in early and late phase among the patients with HIV infection, or the clinical presentation, often resembles post-primary TB in the early phase. In the late phase, resembles primary tuberculosis, as expected. Sputum smear results is often positive, and the late phase could be negative. Chest X-ray often shows cavities in the upper lobes. In the late phase, it shows atypical presentation, often infiltrates mid and lower lung fields lesions. Intrathoracic lymph nodes are seen, infrequent cavities. So ICF at ART centers using four symptom complexes, intensified case finding among adults and adolescents. Current cough, fever, weight loss, and night sweats. In children, cough, fever, poor weight gain, and history of contact with a TB case. Fast tracking and referral to for TB diagnosis. PLHIV found positive for any of the four symptoms should be referred for molecular diagnostics, namely CBNAT or TrueNAT, and other appropriate investigations. So this is a diagnostic algorithm for drug-sensitive pulmonary TB. So you can follow the flow chart. Now, so if you are making a provisional diagnosis of tuberculosis in a patient, and a patient is also co-infected with HIV, treat CBNAT is what you'll have to get. Also, you subject them to smear examination and chest X-ray. The smear comes positive and X-ray suggestive of TB, then subject them to CBNAT and TrueNAT. Smear positive but chest X-ray not suggestive of TB, even then. Smear negative but X-ray suggestive of TB, even then. So, as this slide is self-explanatory, I would welcome your attention on this particular slide. Moving on to the next slide, which is continuous from the previous one. So, once CBNAT is positive for Mycobacterium tuberculosis, we have to look at rifampicin sensitive, indeterminate, resistant, and refer to management of rifampicin resistance. If it is sensitive, then microbiologically confirmed TB and the treatment could be started. So, presumptive extrapulmonary tuberculosis, this slide as you see, it is self-explanatory, and appropriate specimen from the site. If it is available, subject them to CBNAT. If it is not available, high clinical suspicion, then other diagnostic tools you'll have to look at, clinically diagnosis and alternative diagnosis, both you should have. And if available, and also if CBNAT is available, subject them to liquid culture and culture positive and negative. So respectively, you got to treat the patient. So tools for microbiological confirmation of TB. These are the way which CBNAT and TrueNAT functions. So I would be leaving for your discussion at the end of the program. So management of tuberculosis as per NTP. Basic principles of management. So ICF using 4S complex, as we all are aware of that, for TB screening. Fast tracking and referral of symptomatic patients for CBNAT test and the appropriate investigations. If a patient with active TB is diagnosed with HIV, the priority is to start tuberculosis treatment. All HIV tuberculosis co-infected persons are to be initiated on ART within 2 weeks, regardless of the CD4 count. except for TB meningitis. Cotrimoxazole prophylaxis should be given to all HIV TB patients as a primary prophylaxis. Coming to PCP pneumonia, it's caused by, as we mentioned earlier, pneumocystis, jirovecii, pneumonia. Use of ART and prophylaxis for PCP have dramatically reduced the number of cases of PCP. So 20 to 30% PCP occurs in AIDS patients, 20 to 40% associated with mortality even after treatment. 90% occurs when CD4 count is less than 200. Two-thirds healthy children have antibodies to PCP by an end of 4 years of age. In adults, dyspnea is the main symptom. This is the key presenting feature of PCP. Profound dyspnea is seen. Initially, this occurs only on exertion, but later at rest also. Low blood oxygen levels, hypoxemia, can be confirmed with the use of pulse oximeter device. But remember that a rapid respiratory rate can also compensate for hypoxemia, resulting in reasonable oxygen saturation. So, what is the highlight here is dyspnea. Pulse respiratory rate, very high respiratory rate is one of the biggest indicator, clinical sign to suggest it could be a PCP pneumonia. Dry cough, tachypnea, as we mentioned, often with flaring of nostrils, that is, use of accessory respiratory muscles. Temperature may be normal or high and may be over 40 degrees Celsius. Chest X-ray characteristically shows a ground glass appearance that is more pronounced in the lower zones. In children, tachypnea is a significant feature. Dyspnea, cyanosis, sudden onset of fever, chest auscultation is less specific. The intensity of respiratory distress is more important sign. The chest X-ray may show commonly bilateral diffuse parenchymal infiltrates with ground glass or reticulogranular appearance. In mild cases, parenchymal infiltrates predominantly perihilar and progressing peripherally to reach the apical portion of the lung are seen. Rarely lobar cavitatory or miliary lesions, pneumothorax or pneumomediastinum may be seen. So tachypnea in children is defined as respiratory rate. That's what we have mentioned, as we all know about it. So if you can just go through the slide. Clinical presentation. Blood tests and chest radiographs are not pathognomic for PCP. And because the organism cannot be cultivated routinely. Histopathologic or cytopathologic demonstration of organisms in tissue, BAL, bronchoalveolar lavage, or induced sputum sample are required for a definitive diagnosis of PCP. So, coming to the presumptive diagnosis, presence of clinical symptoms, low CD4 count, less than 200, presence of oral candidiasis, suboptimal prophylaxis in the past, like your cotrimoxazole. Then saturation can be used to grade the severity, oxygen saturation. Chest X-ray may support the diagnosis. And also LDH levels. Coming to the definitive diagnosis. Diagnosis can be confirmed by demonstration of organism in pulmonary secretions, by sputum analysis, inducing sputum by hypertonic saline nebulization, by BAL, and transbronchial lung biopsy. PCR is an alternative method for diagnosing PCP. Sputum, sorry. Ah. Sputum collection is often difficult to obtain. Majority of the patients will have dry cough. It can be collected by inhalation of hypertonic saline or or by nebulization. All material coughed out, 2 to 3 ml, is collected and diluted with an equal amount of sterile water. The specimen is liquefied with dithiotol or used as such for preparing smears and staining. It's difficult to induce sputum in children. So coming to prophylaxis of PCP, adults, indication for primary prophylaxis, CD4 count less than 350, WHO clinical staging of 3 to 4. Indication for secondary prophylaxis after the treatment. For all patients who have completed successful treatment of PCP until CD4 count is greater than 350, regimen cotrimoxazole 1 double strength tablets with trimethoprim 160 mg, sulfamethoxazole with 800 mg each day, or 2 single strength tablets daily. Alternatively, if allergic to cotrimoxazole, desensitization to these two compounds may be tried. If severe, in spite of that, if it's severe, then dapsone 100 mg per day can be initiated. Discontinuation. When will you discontinue? So when CD4 count less than 350 on two different occasions with 6 months apart with an ascending trend of CD4 count and devoid of any WHO clinical staging 3 to 4 conditions. So primarily WHO clinical stage should be on 1 to 2 or even less than that. So cotrimoxazole preventive therapy for adults and adolescents. So commencing CPT. So cotrimoxazole prophylaxis must be initiated in all patients with HIV with CD4 count less than 350 cells per mm3 cube or with WHO clinical stage 3 to 4. Timing of the initiation of cotrimoxazole in relation to initiating ART. Start cotrimoxazole prophylaxis first, even before you start ART. Start ART after starting cotrimoxazole or as soon as CPT is tolerated. So once cotrimoxazole is well tolerated, ART is initiated and the patient has completed the preparedness phase for consult. Commencing secondary CPT, we have already told you, once the treatment for PCP is over successfully and CD4 count is well over 350 on two different occasions with 6 months apart. Dosage of cotrimoxazole in adults and adolescents, as I've already mentioned, total daily dosage of 960 with 800 SMZ plus 160 mg of TMP. So cotrimoxazole for pregnant and breastfeeding women. Women who fulfill the criteria for CPT should not be hesitated to continue. They should be continued it throughout pregnancy. If the woman requires CPT during pregnancy, it should be started regardless of the stage of pregnancy. Breastfeeding women should continue CPT when indicated. Patients allergic to sulfur-based medication, then dapsone is initiated 100 mg per day. Cotrimoxazole desensitization program to be attempted, but not in patients with a previously who had previous severe reaction to cotrimoxazole and other sulfur-containing drugs. So prophylaxis. So and monitoring. No specific laboratory monitoring is required in patients receiving cotrimoxazole. Discontinuation, as we have all mentioned, so it's a repetition again. So this is a protocol for cotrimoxazole desensitization. Kindly go through the slide. So this is how you desensitize. This is a 6-day program with dosage of 80 mg of sulfamethoxazole with trimethoprim of 16 mg. And you subsequently, when you tolerate of that dosage, you start increasing every day. So you reach a point wherein the you give a regular dosage, and so you would not. Then the patient has tolerated for 5 days of or 6 days of cotrimoxazole, and then that 6th day you reach a regular strength to be given to the HIV patient. Indication for CPT prophylaxis in children, all HIV exposed infants and children from 6 weeks of age or at first encounter with health services. So, as for 6 weeks of age or first time when they come to the hospital, when to discontinue. So, once HIV infection has been reliably excluded by a negative antibody test at the end of 18 months, regardless of ARV initiation. All HIV infected infants and children up to 5 years of age, regardless of WHO staging or CD4 counts or CD4 percentage. At 5 years of age, when clinical or immunological indicators confirm restoration of immune system for more than 6 months, that is in a child greater than 5 years of age with a WHO staging of 1 or 2 and CD4 count more than 350 cells on two different occasions, not less than 6 months apart. So all HIV infected children greater than 5 years of age went to start cotrimoxazole. WHO staging 3 to 4, regardless of CD4 count, or CD4 count less than 350, regardless of WHO stage. So when clinical and immunological indicators confirm restoration of the immune system for more than 6 months, as we said, it holds good. So 6 months apart, WHO staging 1 to 2, and CD4 count more than 350 cells. As a secondary prophylaxis, children less than 5 years for age do not stop. Greater than 5 years of age, with WHO staging of 1 to 2 and CD4 count of greater than 350 cells. This is after the completion of the treatment for PCP pneumonia. So this is the dosage as per the age and weight of the child. Dosage for cotrimoxazole. Kindly go through this slide. So again, so mild to moderate. What is the dosage? Preferred regimen and alternative regimen. I said dapsone plus trimethoprim 5 mg per kg body weight orally thrice daily. Primaquine is also started as an alternative 30 mg orally daily plus clindamycin 450 mg orally every 6 hours or 600 mg every 8 hours. Atovaquone 750 mg orally twice daily with food. So then alternative regimens. Then moderate to severe PCP, preferred regimen, as we said, it's cotrimoxazole or sulfur-containing drugs. Alternative is pentamidine 4 mg per kg IV daily infused over 60 minutes. Can reduce the dosage to 3 mg per kg body weight. Primaquine, as we said, holds good as it was in mild to moderate, even in severe cases. So dosage is clindamycin straight 600 mg and primaquine 30 mg daily. Duration of treatment is 21 days. So in children, high dose of cotrimoxazole for treatment of PCP pneumonia. Dose given 4 times a day. Dose given at 3 times a day. Syrup and tablet form both are seen. So you can see this is self-explanatory. Bacterial pneumonia. So the most common pulmonary manifestations, as we have discussed, is tuberculosis, PCP, and communicable pneumonia. The incidence of bacterial pneumonia is 0.8 to 2%, 2 per 100%. That's of course 0.8 to 2% per year. Incidence of pneumonia increases by 6 times in untreated HIV patients. Risk factors for pneumonia in real HIV: low CD4 count, especially below 100, lack of ART or intermittent use of ART, tobacco, alcohol, and other IV drug abuse, chronic viral hepatitis, chronic obstructive pulmonary disease, malignancy, renal insufficiency, congestive cardiac failure, underlying pulmonary diseases, bronchiectasis, chronic lung diseases. So the last three is risk factors for children, and COPD, malignancy, and renal insufficiency, congestive cardiac failures, emerging risk factors in older people living with HIV. So clinical manifestations in adults, acute onset, 3 to 5 days of symptoms, including fever, chills, rigors, chest pain, and pleurisy. Cough is productive of purulent sputum and dyspnea. Presence of fever, tachycardia, and hypotension can be indicators of sepsis. Tachypnea and decreased arterial oxygen saturation indicate moderate to severe pneumonia. Children, fever and cough is the primary symptom to note, with tachypnea and chest indrawing. General danger signs: not able to drink or breastfeed, persistent vomiting, convulsions, poor sensorium. Tachypnea, respiratory rate more than 60 per minute in infants who are less than 2 months of age, greater than 50 per minute in infants up to 1 year, and greater than 40 per minute in children aged between 1 to 5 years, and greater than 30 in children older than 5 years. So, classification of pneumonia in children living with HIV: child age less than 5 years with cough and difficulty or difficulty in breathing. Cough and cold, no pneumonia, home care, advise home care. Fast breathing and chest indrawing, pneumonia, oral amoxicillin, and home care advice. General signs of serious illness: severe pneumonia, very severe disease, first dose of antibiotic, and referral to facility for injectable antibiotic therapy. So, recurrent bacterial pneumonia and signs of severity. Recurrences: severe recurrent bacterial pneumonia, current episode plus one or more in previous 6 months. Respiratory rate more than 30, hypoxia less than 90. Children less than 15 years, cough with fast breathing, chest indrawing, nasal flaring, wheezing, and grunting. Diagnosis: findings, the difference between PCP and pneumonia. So, pneumonia can happen at any range. PCP less than 200. Symptoms: non productive cough, ear productive with purulent sputum, chest pain, and high fever. Symptom duration is 2 to 4 weeks. Typically, bacterial pneumonia is 3 to 5 days. Signs: occasional inspiratory dry crepitations, focal lung signs are seen. WBC count varies when bacterial elevated, most oftenly, and neutrophilic in WBC leukocytosis. Neutrophilic leukocytosis is seen. Distribution: normal or diffuse. Pneumonia is more lobar or focal. The location is always bilateral, here it is unilateral. Pattern: reticular to granular. Here airspace consolidation is seen. And pleural effusions, very rare. And in pneumonia, it's seen in 1/3 of the patients. So, cyst in pneumonia in PCP is 15 to 20%, and in pneumonia, it's rare. Management of bacterial pneumonia, general considerations. Treatment duration is 5 to 7 days. Patient should be afebrile for 48 to 72 hours before he is declared clinically stable and discontinuation of therapy. Long duration of antibiotics is often required when severe pneumonia or bacteremia is present, and particularly if due to streptococcal pneumonia or complicated staphylococcal aureus infection. Switch from IV to oral therapy. A switch should be considered for patients who have improved clinically, can swallow and tolerate oral feeds, and have intact GI function. So coming to the most preferred therapy is high dose of beta lactams, amoxicillin with clavulanic acid, along with the macrolide, azithromycin or clarithromycin. In children, oral amoxicillin 40 mg per kg dose is given twice daily for 5 days. Alternative medications are beta lactams again, and cephor, ceph, cepho, cephaloxime or cefuroxime, or a respiratory fluoroquinolone. It could be levofloxacin or moxifloxacin, especially for patients with penicillin allergies. In children, alternatives are beta lactam, cotrimoxazole, and azithromycin. Hospitalized patients with non-severe cases. Preferred therapy, an IV beta lactam plus a macrolide, ceftriaxone, or ampicillin sulfoxaflor, or an IV respiratory fluoroquinolone, levofloxacin or moxifloxacin, especially for patients with penicillin allergies. In children, ampicillin 50 mg per kg or benzyl penicillin 50,000 units per kg IM or IV every 6 hours for at least 5 days along with gentamicin 7.5 mg per kg IM or IV once a day for at least 5 days. Alternative therapy, again IV beta lactam plus doxycycline. IV penicillin may be used for confirmed pneumococcal pneumonia. Severe pneumonia patients, preferred therapy again beta lactam plus azithromycin or beta lactam with IV fluoroquinolone. Could be levofloxacin or moxifloxacin. Preferred beta lactams are ceftriaxone, cefotaxime, or ampicillin sulbactam. Alternative therapy for penicillin allergic patients, carbapenems IV plus an IV respiratory fluoroquinolone, moxifloxacin or levofloxacin. So, who are the patients? The risk of Pseudomonas infection. Preferred therapy is an IV anti-pneumococcal, anti-pseudomonal beta-lactam plus quinolone. So preferred beta-lactams are piperacillin tazobactam, cefixime, imipenem, or meropenem. Alternative therapy, an IV anti-pneumococcal, anti-pseudomonal beta-lactam plus an IV aminoglycoside plus IV azithromycin, or an IV anti-pneumococcal, anti-pseudomonal and beta-lactam plus an IV aminoglycoside plus an IV anti-pneumococcal fluoroquinolone. Patients who are at the risk of MRSA pneumonia, vancomycin IV or linezolid can be used. Coming to Mycobacterium avium complex. In people living with HIV with advanced HIV disease, MAC usually causes disseminated disease. The mode of MAC transmission is thought to be through inhalation, ingestion, or inoculation of MAC bacteria via the respiratory or GI tract. Typically occurs in people with CD4 count below 50 cells mmQ. The patient may present with fever, night sweats, chills, weight loss, muscle wasting, abdominal pain, tiredness, pallor, and diarrhea. There may be enlargement of liver, spleen, and lymph nodes. A confirmed diagnosis of disseminated MAC disease based on compatible clinical signs and symptoms, coupled with the isolation of MAC from cultures of blood, lymph node, bone marrow, and other normally sterile tissue or body fluids. Routine prophylaxis for MAC is so coming to the management of MAC. There. Prophylaxis is not recommended. So management of MAC. Preferred therapy, at least 2 drugs as initial therapy to prevent or delay emergence of resistance. or clarithromycin 500 mg per oral twice daily plus ethambutol 15 mg per kg per oral daily, or azithromycin 500 to 600 mg plus ethambutol 15 mg per kg per oral daily when drug interaction or intolerance precludes the use of clarithromycin. Rifabutin 300 mg per oral daily or fluoroquinolone, example levofloxacin 500 mg per oral daily or moxifloxacin 400 mg per oral daily is alternatives. Criteria of discontinuing the therapy is completed at least 12 months of therapy, no signs and symptoms of MAC disease, and have sustained great CD4 count more than 100 in response to ART for more than 6 months. Coming to tularomycosis, previously known as penicillinosis. Tularomycosis caused by thermally dimorphic fungus Talaromyces marnifac, geographically restricted to Southeast Asian countries, including India. Subacute illness characterized by fever, weight loss, hepatosplenomegaly, lymphadenopathy, and respiratory and GI abnormalities. Skin lesions, central necrotic papules with umbilication appearing on the face, trunk, and extremities occur in 40 to 70% of patients. The pictures that you suggest tularomycosis. Central necrosis. Clinical manifestations, apart from the subacute illness and skin manifestations, uh, so pulmonary, GI, and CNS and others. Coming to pulmonary system, cough, shortness of breath, GI, diarrhea or abdominal pain, hepatosplenomegaly, intra-abdominal lymphadenopathy causes pain. Meningoencephalitis is a rare manifestation and rapid disease with mortality. Others, anemia and thrombocytopenia due to bone marrow infiltration, elevation of aminotransferase is seen with serum aspirate aminotransfer AST over ALT ratio. So this slide ratio of approximately 2 should be considered in all patients with HIV with CD4 count. Um, Presumptive diagnosis, microscopic examination of GIMSA, Reiter Gomery, and methamine silver stained samples of skin lesion scrapings, lymph node aspirate, bone marrow aspirate, or tissue sections. Definitive diagnosis, histopathologic demonstration of the organism in biopsy specimens. Antigen detection and PCR based methods are promising rapid diagnostics currently being evaluated. Okay, so prevention and management, preferred therapy, induction therapy with liposomal amphotericin 3 to 5 mg per kg per day, IV for 2 weeks, followed by consolidation therapy with itraconazole 200 mg orally twice daily for 10 weeks, followed by maintenance therapy or secondary prophylaxis with itraconazole 200 mg oral daily. Alternative therapy, induction therapy with deoxycholate amphotericin B 0.6 mg per kg per day, IV for 2 weeks, followed by consolidation therapy with itraconazole 200 mg orally twice daily for 10 weeks, followed by maintenance therapy or secondary prophylaxis of itraconazole 200 mg daily. Criteria for discontinuing maintenance therapy is CD4 count more than 200 cells for greater than 6 months in response to AR. So other pathogens with pulmonary manifestations, histoplasmosis. So progressive disseminated histoplasmosis presents with fever, fatigue, weight loss, and hepatosplenomegaly. Pulmonary manifestations such as cough, chest pain, and dyspnea. CNS manifestations like fever and headache. And if brain involvement is present, seizures and focal neurological deficits can be seen with altered mental status. GI manifestations like diarrhea, fever, abdominal pain, and weight loss is seen. Diagnostics, CSF findings with lymphocytic phagocytosis, elevated protein and low sugar. Fungal stains are usually negative, and CSF cultures are positive in the majority of cases. Histoplasma capsulatum can be cultured from blood using lysis centrifugation technique, bone marrow, respiratory secretions, or from sample from other involves in greater than 85% of people living with HIV and disseminated histoplasmosis, but the organism requires several weeks to grow. Detection of histoplasma antigen in blood or urine is a sensitive method for rapid diagnosis of dissemination and acute pulmonary histoplasmosis, but is insensitive for chronic forms of pulmonary infections. Management, liposomal amphotericin B, again 3 mg per kg IV daily for at least 2 weeks or until clinically improved, or deoxycholate amphotericin B zero point 0.7 to 1 mg per kg IV daily for 2 weeks. Maintenance therapy is by itraconazole 200 mg orally thrice a day for 3 days and then 200 mg twice a day. So at least for 12 months. So less severe disseminated disease induction maintenance therapy, itraconazole 200 mg orally for 3 times a day for 3 days and then 200 mg twice a day. Duration is at least 12 months. Nocardiosis. The most common symptoms are present at presentation are chronic cough, chest pain, dyspnea, and hemoptysis. Pulmonary nocardiosis is a chronic disease which can rarely have an acute course as well. It rarely has skin involvement with subcutaneous ulcerated nodules and disseminated form as nervous system involvement with symptoms like headache, altered sensorium, and ataxia. Chest radiograph findings of pulmonary nocardiosis is advanced in advanced HIV infection include alveolar infiltration, cavitation, pleural effusion, and reticulonodular shadows. CT finding of the chest shows multiple nodules in almost all patients and cavitation in majority of the patients. Bronchial washings are shown to be useful, bronchoalveolar lavage, for isolation of nocardia. Nocardia may take several days to weeks to grow in culture. Sputum smear with quinone acid-fast stain reveals acid-fast branching filaments of nocardia. Treatment again, cotrimoxazole with amic acid or imipenem. It's for 6 months. Aspergillosis. So, what are the clinical manifestations? Three clinical manifestations: allergic bronchopulmonary aspergillosis, aspergillosis mycetoma or fungal ball, invasive aspergillosis. This occurs in people living with HIV mostly and presents with high fever, pulmonary consolidation, and hematogenous spread. Symptoms include fever, dyspnea, cough, chest pain, and hemoptysis. Chest radiograph shows thick walled cavities, most commonly in the upper lobes. Culture of organisms, if possible. Management, liposomal amphotericin B or the combination of capsofungin and voriconazole should be considered. So, COVID 19 in PLHIV, multiple system involvement, looking at pulmonary, liver, renal, neurological, including ocular, like epiphora, conjunctivitis, and chemosis. Dermatology, erythematous rash, widespread urticaria, chickenpox like vesicles. Cardiovascular, arrhythmias, myocarditis, pericarditis, acute coronary syndrome, including heart failure, and GI symptoms. Mild disease, you see upper respiratory tract infections with or without fever, without shortness of breath. Moderate dyspnea, evidence of lower tract respiratory disease with SpO2 of 90 or less than 93 at room, and respiratory rate of 20 greater than 24 per minute. Severe, you see oxygen saturation less than 90% on room, and you see lung infiltrates, and you also see signs like tachypnea and hypoxemia. Risk factors responsible for severe disease or mortality among PL-HIV: people who are 60 years and above, cardiovascular disease, hypertension and coronary artery disease, diabetes and other immunocompromised status, chronic lung, kidney or liver disease, previous cerebrovascular disease, and with morbid obesity. So, with these, we conclude the opportunistic infections in the respiratory system in people living with HIV, including children, adults, adolescents. So, I hereby ask Shweta to take over.
Thank you so much, sir, for facilitating this important session. Any questions from the participants, please feel free to put your questions in the chat box, or you can now unmute and ask questions. Any questions from the participants?
ಕೇಳಿ ಇದು ಎಷ್ಟು ವಯಸ್ಸಿರ್ತಲ್ಲ ಮೆಜಾರಿಟಿ ಏನೇನಿದೆ ಅಂತ
So I don't think there are any questions. Thank you so much once again for facilitating this session. Thank you to all the participants for patient listening. Sir, can we conclude the session now? You are on mute, sir.
Yeah. No, we can. And if you find any questions to be addressed, I think there's no questions as such. And also, you have to hold some quiz or something, Shweta. So,
No, sir. No, not for this session, sir.
okay, all right.
Yeah, thank you so much, sir. Thank you so much.
Thank you. Yeah.
Kiran, sir, we can conclude the session.